Good morning, everyone. Again, so over the next few minutes, I'll be discussing about arrhythmias and conduction abnormalities. I'm pretty sure many of you would have come across the scenario when there's a ECG with any tachyarrhythmia or any arrhythmia in front of you, and you're just wondering, what is this? What to do next? How to interpret this and how to manage this scenario. So let's try to simplify and understand arrhythmias. So tachyarrhythmias. When you come across any tachyarrhythmia in your ECG, the first thing you need to see is what is the complex, whether it's a narrow complex or a broad complex. That is the QRS, it's more than 120 milliseconds or not. Second thing, whether it's a regular or irregular. If you are able to decide on these things, then you will be able to pinpoint your diagnosis to certain conditions. If it's a narrow and regular tachycardia, most commonly sinus tachycardia. Then atrial flutter with fixed block, or AV NRT or AV RT, that is AV nodal reentry tachycardia or atrioventricular reentry tachycardia. If it's narrow complex, irregular, then atrial fibrillation, most commonly. Wide complex, regular, ventricular tachycardia. SVT with bundle branch block, paced rhythms, or pre-excited SVT. And wide complex, irregular, polymorphic ventricular tachycardia. Other than this, atrial fibrillation with bundle branch block or pre-excited syndrome with atrial fibrillation. So, what do you understand by supraventricular tachycardia? Supraventricular tachycardia is when the impulse is arising above the his Purkinje fibers. It can be atrial or it can be AV junctional. Atrial, like your sinus tachycardia, atrial flutter, atrial fibrillation, multifocal atrial tachycardia. AV junctional be AV nodal reentry tachycardia and atrioventricular reentry tachycardia. Difference is the accessory pathway, location of accessory pathway. If it is within your AV node, then it is AV nodal reentry tachycardia. Or if it's outside AV node, commonest being bundle of Kent, it is atrioventricular reentry tachycardia. What do you see on ECG? Tachycardia with rate of 140 to even up to 280, 300. How do you differentiate from sinus? In sinus, your rate will be maximum 220 minus the age of the patient. If the rate of your tachycardia is more than that, it has to be SVT. Narrow complex and P-wave. P-wave, mostly absent. If it is present, it might be embedded inside your QRS complex, it might be visible after the QRS complex, or it can be an inverted QRS, inverted P-wave. That is mostly because of the retrograde conduction through your accessory pathway. So the vector is directed upwards. That's why you will get a P-wave inversion in your inferior leads. So what do you see on ECG? Narrow complex, regular tachycardia, and P-wave, like you can see here, after the QRS complex. How do you treat it? Vagal maneuvers. What are vagal maneuvers? Valsalva maneuver and carotid sinus massage. Valsalva maneuver is when a person is breathing against closed glottis, generating a pressure of 30 to 40 millimeters mercury, or carotid sinus massage. So, what happens when vagal maneuvers are done? If it is an atrial tachycardia and because of the rate, your P-wave is not visible, your heart rate will come down and P-wave will be visible. Or if it is a supraventricular tachycardia, then it will go back to its normal rhythm. Then adenosine. What is adenosine? It is a short-acting, extremely short-acting antiarrhythmic. Half-life 10 seconds. Action lasts up to 30 seconds. It acts on the A1 and A2 receptors in the SA node and AV node, depresses their activity, increases the refractory period, and hence it helps in the supraventricular tachycardia. The rhythm coming through the accessory pathway, when it reaches the node will be in the refractory period, so it won't get conducted. The main problem with adenosine, flushing, bronchospasm immediately after administration, or feeling of impending doom. If you would have met any patient who has received adenosine before, patient will completely refuse to take the drug again. Chest pain. The main use of adenosine is in diagnosis as treatment of supraventricular tachycardia. How does it help in diagnosing? It's based on the response we see after administering adenosine. If there's no change in rate, either we have not given adequate dose, that is first dose of 6 mg, second dose can be repeated at 12 mg, third dose again 12 mg. So if your dose is not adequate, that can be the reason for no response, or if it is a ventricular tachycardia. Otherwise, you can see a gradual slowing, then again it goes back to its normal rhythm. What's the cause? Sinus tachycardia or any other atrial tachycardia arising from outside the AV node. Sudden termination, AV nodal reentry tachycardia and atrioventricular reentry tachycardia. Or the rhythm is still persistent, there's no change after adenosine. That is atrial flutter or fibrillation. So next, after vagal maneuvers and adenosine, the main thing we need to see is the patient is stable or unstable. This is the slide I want you to take from here. From the whole presentation, this is the main thing. What you need to know is whether the patient is stable or unstable. 5 things which determine: hypotension, signs of shock, acute heart failure, chest discomfort, and altered mental status. If any of these things are present, patient is unstable. What you are going to do? Synchronized cardioversion. Be it any tachyarrhythmia. If the patient is unstable, you are going to do a synchronized cardioversion. If the patient is stable, then what you do? Then beta blockers, calcium channel blockers like dilsem and verapamil. If still there is no effect, you can still go ahead and try synchronized cardioversion. Coming to pre-excitation syndrome. There are many pre-excitation syndromes. Most common which you had seen and heard is Wolff-Parkinson-White syndrome. How does it present? What exactly it is? Like we said, like in atrioventricular reentry tachycardia, there is an accessory pathway outside the AV node, bundle of Kent. The accessory from there, the impulse reaches before the impulse can reach from the AV node. Hence, what you will get is a PR shortening, then a slurred upstroke, because ventricular depolarization happens through the accessory pathway, not through the AV node. And again, because the whole depolarization happens through the accessory pathway, the QRS gets prolonged. Also, you can see pseudo Q waves and discordant QRS STT changes. How do you manage? Unstable, synchronized cardioversion. Stable patient, you go ahead with sotalol, beautiful drug, amiodarone, flecainide, commonly used drugs. And long-term therapy, ablation. If you get a patient with AFWPW syndrome, what will be the rhythm? It will be a completely irregular tachycardia. Completely chaotic rhythm will be there. Wide QRS complex. Rate can be up to 250 to 300. The thing I need you to remember from here, only indication where amiodarone is not given in atrial fibrillation. That is pre-excitation syndromes with atrial fibrillation. That will worsen, decrease the refractory period of your AV node and increase conduction through your accessory pathway. It will worsen the atrial fibrillation. Drugs to avoid, all AV nodal blocking drugs, adenosine, beta blocker, calcium blockers, digoxin, amiodarone, all AV nodal blocking drugs are to be avoided. Coming to our first case. This is a 32-year female case of hypothyroidism, presence to ER with palpitation. What do you see in the ECG? Narrow, irregular rhythm. P waves are there? No. Atrial fibrillation. What are the causes of atrial fibrillation? Catecholamine axis. It can be exogenous, you are administering adrenaline, or it can be endogenous, that is subarachnoid hemorrhage, thyrotoxicosis, like in this case, or causes of cases with atrial dysfunction, pulmonary hypertension, septal defects, mitral stenosis. Abnormality in conduction systems, or increased atrial automaticity. Atria is arrhythmogenic, the holiday heart syndrome, electrolyte derangements, myocarditis, all these can cause. What do you see in the patients with atrial fibrillation? Most commonly, because atria is not contracting, blood will accumulate, thrombosis. Next, atrial kick is lost. So your cardiac output will come down by 20 to 30%. Hypertension, decreased diastolic filling, because again, there's no adequate, because of tachycardia, no adequate time for the LV filling. And in long-standing atrial fibrillation, rate-related cardiomyopathy can happen. How do you manage? Three main things. Management of prevention of thromboembolism, prevention of stroke. Then rate control and rhythm control. And third, management of the causes, all the modifiable or reversible causes. How do you assess for thromboembolism? Chad-VAS score. Difficult to memorize, but I want you to remember two things which has more importance. That is age more than 75 and prior history of TIA or stroke. Both of these have 2 points. If your patient is, gets a score of more than 2 in this, there's a high risk of thromboembolism. Patient should receive oral anticoagulation. Then coming to rate control, rhythm control. AHA guidelines say first thing you need to do is control the rate. How do you control the rate? IV amiodarone in critical ill patients. If your patient is still stable, you can go ahead with beta blockers, calcium channel blockers. And like I said, in pre-excitation or WPW, avoid AV nodal blocking drugs. Digoxin can be considered, but it's not rapidly acting. Your action will be slow with the digoxin. Rhythm control, cardioversion. Pharmacological agents, again amiodarone, procainamide, flecainide, but only in structurally normal heart. And hemodynamically stable patients. So, coming to our second case. This is a 58-year-old man came to ER with a typical chest pain of acute coronary syndrome along the precordial chest pain radiating to arms, and patient is diaphoretic, some hypotension. And this is the ECG you see. What are the complexes? Wide complex. Can you see any P waves? So, what is this? Ventricular rhythm. What you see in ventricular rhythm? Wide QRS complex, no P waves, no PQRS association. Rate can be 20 to 40. If the rate is 20 to 40, what is it? Many times you'll see. With just ventricular rhythms, beats are there, but rate is less. That is ventricular escape rhythm. Rate of 40 to 120. Accelerated idioventricular rhythm or accelerated ventricular escape rhythm. Rate of more than 120, ventricular tachycardia. So what can you see in this? How are the complexes? Wide complex. P waves are there? Yes, one P wave. But if you see, it's a 6-second ECG, only one P wave. So what's happening here? Sinus pause with ventricular escape rhythm. What's happening in this? QRS, wide. Then, what's the rate? 40 to 110. P waves are there? Yes. P waves are at different rate than the QRS. What is the situation? Accelerated idioventricular rhythm. Will you treat it? No. When do you see accelerated idioventricular rhythm? When successful perfusion has happened after occluded coronary vessel. If you are treating it, suppressing this rhythm might further worsen the situation. So treatment is to simply observe. Coming back to ECG, this ECG, what is going on here? Ventricular tachycardia. What do you commonly see? Broad complexes, more than 160 seconds, absence of LVBB, RBB morphology, AV dissociation, positive or negative concordance. What do you mean by that? All the waves, all the QRS will be either positive or either negative in the chest leads. Like you can see here you can see the two, you are able to see the two waves, right? What happens in RBBB? The left rabbit ear is taller. Sorry, right rabbit ear is taller. Here what you can see is the left rabbit ear is taller. Then fusion beats, capture beats. Fusion beat is when supraventricular beat is getting fused with the ventricular beats. Capture beat is when in a run of ventricular tachycardia, occasionally the supraventricular beats are getting conducted. or you are seeing a notch above the nadir of S wave, known as Josephson sign, or the RS interval in any one of the precordial lead, if it's more than 100 milliseconds, known as Brugada sign. If any of these are present, these are morphologically diagnostic of ventricular tachycardia. How do you differentiate? Even SVT with bundle branch block, like we saw on the first slide, that SVT with bundle branch block or aberrancy can be having a wide complex tachycardia. How do you differentiate? Absence of RS complex in all the precordial leads. R2S interval, that is the Brugada sign, more than 100 in even one precordial lead. AV dissociation is absent, and none of the morphological criteria of VT is fitting in. In that case, we can label it as supraventricular tachycardia with aberrancy. In any case, if it is a wide complex tachycardia, assume it to be a ventricular tachycardia until proven otherwise, and treat it as a ventricular tachycardia. How do you treat it? Same. SS for stable, unstable. If unstable, synchronized cardioversion. Refractory, you can consider antiarrhythmic agents. If stable, then again wide or narrow, and you can manage it accordingly. And amiodarone, great class 3 antiarrhythmic agent. Mechanism, potassium channel blocker. However, works through almost all the classes. That is, it is sodium channel blocking action, calcium channel blocking action, beta blocking action as well. It is FDA approved for pulseless VT and wide complex tachycardia. Atrial fibrillation is still an off-label use for amiodarone. Adverse effects: hypothyroidism, liver toxicity, pulmonary toxicity, phototoxicity, high-grade AV blocks. So the patient, which we saw, the last ECG, the patient was cardioverted and there was response. But again after this, the patient had multiple episodes of monomorphic VT over the whole day. What is the situation? How will you manage it? Refractory VT or electrical storm. When there are more than 3 episodes of ventricular tachycardia in a day, label it as refractory VT. Treat it as electrical storm. Management, same, antiarrhythmics, lignocaine, other than amiodarone. Other non-medical management, left striate ganglion block, overdrive pacing, IABP, treatment, revascularization, or mechanical support device. Left striate ganglion block helps basically to cause, it causes sympathetic denervation of the heart, and that's how it helps in increasing the fibrillation threshold. Other strategies, double sequential defibrillation. Quick succession, you give shocks, or you give a vector change, that is anterior-posterior. One is both the paddles anteriorly, second is anterior-posterior. Coming to bradyarrhythmias, what exactly is happening here? Anyone? If you notice the PR interval is getting prolonged. What is it? First degree heart block. Causes increased vagal tone, athletics, electrolyte disturbances, use of AV nodal blocking drugs, or can be seen normally. Treat it? No. No need to, it's normal variant, no need to treat. In this ECG, if you will notice, your PR interval is gradually getting prolonged, known as Mobitz type 1, Wenckebach's block. Problem is, AV node is diseased. Causes, beta blockers, CCBs, increased vagal tones, MI, myocarditis, or yes, commonly after MVR, cardiac surgeries. Asymptomatic, no treatment needed. Symptomatic, treat with atropine. Type 2 Mobitz block. Your successive beats, QRS is getting skipped. Problem here is his Purkinje system, bundle of his, is getting damaged. Cause, mostly inflammatory cause, fibrotic changes, MI, anything which is damaging the bundle of his. The depolarization wave is coming through the AV node, but it's not getting conducted, so you get a missed beat. Problem can happen, go into ventricular standstill, can have sudden cardiac arrest, so you need a pacemaker. What's happening here? The P waves, regular? Yeah. QRS, same rate, AV dissociation present? Yes. What is the cause? Anything else you can notice? ST elevation in inferior leads. Inferior wall MI causing complete heart block. Treatment, pacemaker is needed. Any bradyarrhythmia, again, symptomatic, asymptomatic. Asymptomatic, just monitor and observe. If it's symptomatic, transcutaneous pacing, dopamine and epinephrine. Lastly, bifascicular block. When you see, there are basically 3 fascicles, right bundle branch, left bundle branch, that has anterior fascicle, posterior fascicle. If any 2 is getting blocked, that is RBBB with left anterior or left posterior, evidenced by presence of left axis deviation or right axis deviation, you get a bifascicular block. Trifascicular, if you have a 3rd degree heart block along with the bifascicular. Causes of impending trifascicular block, any normal rhythm with alternating LBBB and RBBB, or RBBB with alternating anterior and posterior fascicular block. How do you treat urgent pacemaker? So at the end, the most important thing I want you to take out from this presentation is whether patient is stable or unstable. That's all. Thank you.